Hello and welcome to today's webinar, Exciting Updates to Get with the Guidelines-CAD. My name is Sandeep Gill. I'm the Health IT Product Manager that manages Get with the Guidelines-CAD. I'm joined by fellow HA staff Jason Walchuk, Melissa Clark, and Mindy Cook. Before we get started, I'd like to go over a few items so you know how to participate in today's event. This webinar is being recorded and will be available via email within 48 hours. There are no CEs associated with this event. If you experience any technical issues during this presentation, most can be resolved by refreshing your browser. If your issue is not resolved following that refresh, please refer to your GoToWebinar registration confirmation email with instructions for checking system requirements for participation. You can submit a question by typing it into the question pane of the control panel at any point during this webinar. We'll answer some via chat and hold others to answer live at the end of the webinar. I will now hand it over to Jason Walchuk, National Director for Program Development Health IT, to start us off.
Thank you, Sandeep, and welcome everyone. It's a pleasure to be here today to present to you a few exciting things. I know it's been a few minutes. We were just talking prior to starting the webinar, a few minutes since we've really been in front of you, talked to you about the registry. We wanted to take this opportunity, late in December, to give you all some pertinent updates that are coming to the registry. A few important updates and a webinar that's coming for the Targets Type 2 Diabetes Honor Roll, and then also Mindy Cook, our lead for rural health here at the American Heart Association and Quality, is going to present a bit on the new Rural Acute Recognition Program and the webinar that will be held later next month. So in general today, what we're going to go through in the beginning is an overview of what is being deemed CAD version 3. So version 3 of the form really is a new opportunity that we're going to be going into the next year that is going to leverage a lot of the feedback and input and user cases that you have all provided to us over the years through our development. We're taking the opportunity in 2023 to refresh the form, to modernize it, to organize it in a way that flows better for you all, to address questions and comments that you had about patient populations and expanded patients and opportunities within the registry, to really move in the direction of getting the Get With the Guidelines tool to a quality improvement solution for you, for your cardiovascular, your STEMI, NSTEMI, high-risk chest pains, and any other cardiac alert systems that you have in your hospital. A way that you have a system and a registry to capture those data, provide you with meaningful reports and meaningful metrics that will help drive your quality improvement at your hospitals. So, Sandy, if we can go back for a minute. So beginning next year, we will be launching the new version 3 of the form. What that means is in a period of time, once that's released, all hospitals will move over to this new form. It'll be a streamlined data capture that'll definitely enhance your abstraction view. The vast and the bulk majority of the data elements and everything that you came to love and that you use within the tool is all going to be there. It's just going to be structured a little differently, organized in a better workflow with better hide, clear, and logic to really, I think, enhance how you abstract. Additional updates are going to be put into the tool to enhance reporting, filtering, and other metrics for you to have, better opportunities to use the data within the system for your quality improvement goals. And what that means is more granular data around door in, door out timing for both receiving and referring hospitals, reasons for transfer, reasons for delay, the agencies around those transfer systems for interfacility. A lot better data in a more meaningful way that allow us to provide you with tools and reporting to go above and beyond just the standard achievement and quality measures that are currently in the tool. So all of this, again, has been inspired by all of you that have been working with our field staff diligently, providing feedback, giving us suggestions and updates. We try to incorporate as much of that as possible. And also this next year, we're going to be moving into the direction of having a specific Get With The Guidelines CAD user group that's going to be made up of users like you from across the country, that's going to provide us real-time expertise as abstractors and clinical coordinators at the hospitals as we develop and put these tools into the system. So we're really looking forward to that. We've had great success with some of our other registries, such as stroke and heart failure. So we're really looking forward to working with you on that. But at the end of the day, the Mission Lifeline section of this registry, it still supports that. It's still the engine of Mission Lifeline. All the recognition and awards will all maintain the same currently into 2023. Go ahead, Sandeep, next slide. So why version 3? So what version 3 is that originally within the Get With The Guidelines CAD registry, when it was in the patient management tool, that was version 1 of the form. When we migrated data over and we rolled out the Get With The Guidelines CAD registry within the new system several years ago, that was version 2. You've been in version 2 for all of this time, all of your abstraction and all the data that you put into the system, and to keep that data and the integrity of it, we do versioning of the tool. So that is when version 3, when that is released, all systems basically will move over to that third form. The version 3 form also is going to be tied in directly and used for the Rural Recognition Program, which Mindy Cook later on in this webinar will give you some more details and the opportunity to go to the webinar to hear more details on that. So all of these things are kind of happening in tandem. We find that this will be a significant update to the registry, which is why it's a full version, with just some minor updates to data elements, but really more of a layout and a feel for you as you abstract. Go to the next slide, Sandeep. So what are we talking about here? An update to the interface, really to bring this thing, Get With The Guidelines CAD, from a registry to more of a quality improvement tool, to provide you with opportunities to have more streamlined data capture, to improve logic so that it speeds up your abstraction, and the elements and the pertinent questions that are in front of you make sense, right? They're labeled appropriately, they're clear in context, they're organized in a way so that when you're answering pertinent questions, they're displayed to you in an appropriate fashion and in an appropriate way. We also wanted to give you options and other tools to use within the registry that'll come later in the year. But to do that, we also wanted to make the registry more broad and more open and allowing for a broader patient population for those of you that have asked for that in the past, asking for high-risk chest pain patients to have cardiac lists and maybe your STEMI alerts at your hospitals that end up not coding out as STEMIs. We want to make those available within the tool for you to enter those patients in if you choose to. The patient populations related to the achievement and the quality measures for your STEMI referring and receiving and NSTEMI, those will maintain the same. Those are still those same populations. The measures still use the same logic, but we don't want to restrict the registry to just those patients if hospitals choose to enter in others. So entering in those patients, we also want other additional patient populations. We also want to provide you with tools so that you can measure performance and care in those patients through your ED and maybe up to your cath lab or through to discharge. Also, with some of this enhanced data elements and the enhanced form will give us the ability to do a better patient drill down into some of these specific patterns and transitions of care. And we're going to get into that a little bit in the future here. Sandeep's going to go over some of the ECRF updates. But for instance, door in, door out, reasons for transfer, reasons for any delays in transfer. Instead of just documenting that there was a non-system reason with a checkbox, we're now going to get into more granular, what were those reasons? Document those in discrete fields so that you can stratify that and look for actual holes and reasons for system improvement from both at a hospital level, a system level, a state level, and then at the national level. And then obviously, this will also continue the support that we have and really align us well to continue the cardiac certifications joint with Joint Commission for primary, acute, and comprehensive heart attack certifications. We'll move into the next slide. So what's is not changing. I think sometimes it's good to, put this into the framework of just to level set everyone. This is not a new registry. This is not a significant departure from anything that you're familiar with. All of the mission lifeline recognition criteria, the data capture, all of that will remain the same. You'll see minor updates to labels, locations, where elements are, and more discrete fields for reasons for delay, transfer, and that. It's a single form for all, so the flow will work regardless of what type of institution you are. Only pertinent questions will be displayed depending on what care you provide or what capabilities you have. So all of that will remain the same. Again, the entry criteria, initial patient populations for all of the referring, receiving, and NSTEMI will all remain the same. Those same elements are still present on the form. No change there. Your internal abstraction process, again, doesn't change. If you are a hospital that only enters NSTEMI patients for the STEMI awards, you can maintain that. If you do NSTEMI, you can continue to do that. There is a new opportunity for you to enter in some chest pain, high-risk chest pain patients and beyond. Those, again, are optional patient populations, but the tool is now going to be positioned to allow you to put those in and pull those patients out via the time tracker and some future metrics that we're going to be providing as reporting measures. And it will continue to support all your cardiac certifications. So there's no interruption, no change. All of that will remain the same. Let's go to the next. So let's talk a little bit more about what is involved then with CAD version 3. So really, again, we're trying to expand on the success that you all have made, get with the Guidelines CAD, and really move the direction of providing a quality improvement tool for your ACS, all of your ACS patients within your hospital or your health system. So it allows sites to choose what data that they're going to put in those expanded patient populations. We have heard from the field many times that, our focus in our data system of STEMI and NSTEMI really didn't allow for a lot of output and collection of some high-risk chest patients that you guys do focus in on quality improvement, and also look at your response to those patients. So we want to open up the tool and provide an opportunity for you to enter those patients in so you can have a sole quality improvement system to benefit from all of those metrics and things that we have within the Get with the Guidelines systems on all of these subpopulations as well. We want to enhance that data capture for single dynamic case report, again, so it flows based on how you abstract and what capabilities. For instance, if you transfer a patient out and the ED disposition is transfer, then you'll see the transfer section of and where you set the patient out, the reasons why, and all those. But you'll never see any of the other downstream care if you never, gave lytics or provided thrombolytic or PCI or any of those. However, if you're in the receiving hospital, you won't see any of the transfer out metrics or data capture. You'll see metrics related to how the patient was transferred to you and where they were. So the form, because of the technology that we have within the registry, we're able to provide that with hide, clear, and show logic to really streamline and make that form appropriate for you and your facility as you're abstracting. New transfer section, again, updates for reasons for delay and all types of treatments. This is going to provide us with better granular data to drill down in those patient populations, to look at patterns, reasons that you perceive within your hospital for delays that you're seeing to truly do quality improvement on those patients. And then in the future, later down into this year, we're going to have more webinars that are going to explain some of the tools and reporting that we are going to provide to you, utilizing and leveraging this new V3 form. So we're going to look at measures and reports that are focused on some of those separate patient populations above and beyond the STEMI and NSTEMIs. We're going to look at focus feedback tools that'll provide one-shot, simple graphs and feedback metrics to individual providers at all different levels. But think of it as a report that you can pull out for individual care to that individual provider. So there'd be a separate one for the ED, separate one for EMS, showing them metrics that are pertinent to them. And then we want to look at all those care segments, time trackers, feedback tools. And then also one exciting thing that we have in the works for EMS, but we're also developing for transfer sites, is data sharing Think of it as pulling data in from another Get With The Guidelines CAD system. If a patient's entered in and transferred to you, you'll be able to retrieve certain pertinent elements that you need to populate your form related to the transfer of that patient, the time they arrived at the hospital, the time they were transferred out, where they came from, and those pertinent variables. Connects those two records. That would be a huge advancement in our system. We're already doing something similar with EMS from image trend through our EPCR, pulling in those EMS variables in stroke. So we are looking this year to roll that out into CAD as well. So be on the lookouts for some of those excitement opportunities. Go next slide. So we're going to, next couple slides, we're going to go through the entry criteria. It's really the same for if you're participating in STEMI and NSTEMI, really no change. This is what we're showing is new opportunities and new expanded patient populations that the registry and the system will allow to be entered. Again, the metrics and the awards are still tied to the same, STEMI ECG for the STEMI and NSTEMI. No STEMI ECG and positive clinical biomarkers. So none of that is changing. Quality, all those measures for the awards. This is truly just allowing a broader net for the patient population, if you choose to enter those in, to benefit from a lot of the time tracker and metrics that we have within the system. So the boxes around that third population, which historically within the Get With The Guidelines CAD system, we haven't focused on or asked to be entered, and that is chest pain patients, principal diagnosis of angina or chest pain. This really ties into the rural project that's going to be rolled out this year, is that there are specific metrics within that population, within that award that will be on chest pain. At this time, we don't have anything for the broader Mission Lifeline award, but it doesn't mean down the road that something is not going to be developed. So we're preparing the registry to set up in a way so that these patients can be captured. So we, based on feedback from you all. Go to the next slide. And so to drill down on that, and again, in our entry criteria currently with this system, we do provide these two tables for STEMI and NSTEMI of applicable ICD-10 codes that can be used to identify these patients that we want entered. We're also going to provide you with a list of applicable chest pain codes that could be used by you to identify those patients within your hospital. This also includes, remember, we want to capture patients that are treated for those cardiac symptoms. So if they're treated for a STEMI or NSTEMI, even if they're later transferred and expired, we want those patients entered in. No change there. We'll go to the next slide. But there are certain patients we really don't want entered into the system, and those are patients less than 18 or patients that arrive at your hospital for a planned scheduled procedure. This new optional section is, we're just providing this as better clarity based on feedback from a lot of users, was, can we enter in these chest pain patients? The thing kind of says maybe not, so there's a little unsure. So we wanted to make this as clear as possible that if you have a patient that has a secondary diagnosis, but you are tracking that patient for your hospital's response to their angina or chest pain, feel free to enter those patients in. We're going to have tools and metrics for you to utilize that for quality improvement if you choose to enter those in. We also want to capture at the very bottom there, is another one we get quite often, is all of the patients that you may have on your cardiac log. Some may not code out to be STEMIs, but they're all, part of that response system. You want to have metrics. You want to track those patients in a central location, and we want to provide Get With The Guidelines CAD to do that for you. Also, any in-hospital AMIs, right? Currently within the system, we don't ask for those to be entered. They're not included within the metrics, but are in the award criteria. But just like in our other disease states, we are looking to provide in-hospital response metrics and reporting measures for you, for those of you that do enter those patients in, so those will come in the future time. So that's another optional patient population that you'll be able to enter. We'll go to the next slide. And so that's a bit of an overview. I'm going to hand it over right now to Sandeep Gill, who's our product manager for Get With The Guidelines CAD, who's going to go into some more details of the updates that are going to be involved in the ECRF. Also, I forgot to mention at the very beginning, this is not the last webinar. We're taking this opportunity in early December to give you this information, but be on the lookout. And I think we have a timeline slide that's coming up later later in January, where we're going to be able to pull the form up, show it to you, and give you a tour through it long before we're going to see the update come in February. So Sandeep, thank you.
Thank you so much, Jason. Yeah, so I'm going to just talk a little bit more about the exact ECRF updates that you're going to be seeing. We do have a few screenshots of what's in development right now, and as Jason mentioned, we will be holding an additional webinar in January where I will be able to show you a lot more. A lot of this is still in development, and we don't have it available to show to you just yet. But just some key things I wanted to point out. We have updates so that we can collect data for ED disposition, EMS, ECG finding. As Jason mentioned before, the transfer section for both referring and receiving will now have reasons for transfer as well as reasons for delay. And I do have a little bit of that to show for you guys. And we will also have, some items like final clinical diagnosis. We redesigned some sections that are very familiar to you guys, like medications prior to admission, thrombolytic administration, our PCI section, reasons for delay, as Jason mentioned, and I will be showing you a little bit of that as well. We've also created a whole NPI section to kind of pull those together into one area and added additional physician fields so you can track additional physicians. These are not exhaustive lists, and we will be giving you a lot more information as we get closer to all the different updates that are going to be happening. But these are just some of the key ones that I've heard a lot of personally that have been looked for. So we hope you're just as excited as we are. So first, I just wanted to show you guys a look at our new tabs. These were redesigned from a chronological patient care perspective, the patient's demographics, their admin, arrived at your hospital, now any pre-hospital information that you've collected, evaluating them for their cardiac evaluations, in-hospital medications, PCI, and then discharge. A little bit more user-friendly and just a little bit more logical in care. All the previous elements that you're used to exist in the appropriate tabs, and we hope this helps with your abstraction. As promised, here's a little screenshot that I am able to share with you guys right now. This is our reasons for transfer for the referring section. What I want to point out here is that there's logic built in, so this is not something that as a receiving center you'll see unless for some reason you refer to patient. It's here where there's ED disposition. Once you hit transfer to acute care, the reason this whole transfer data section will show, and the reasons for transfer from this facility will then show, and you'll be able to select all the reasons. This is a multi-select, so we think that's important. You can note all the different reasons why there was a transfer, and this will help in drilling down later if you're trying to figure out, well, what are all the reasons that we transfer? Is it usually for PCI? Is there another reason? We'll be able to drill down a little bit more in that. And then I wanted to highlight here, we also have was there a documented reason for delay in transfer? And this is a yes, no. A lot of our reasons for delay that you guys are used to are check boxes. We've kind of moved away from that into yes, no questions, and that'll help for data pulls. And we've also moved away from just saying non-system reasons. So we are able to collect all the reasons for delay. And what we've noted here are non-system reasons don't have asterisks, and that means that they will be excluded from measures as you guys are used to. And any reasons that are system reasons that are going to be fallouts will have asterisks here, and they're at the bottom of the list in alphabetical order. So that's a change that you're going to see across the board. And we'll go ahead and move to our reasons for delay. A little bit more examples here are we have our ECG non-system reason for delay, and we have our EMS non-system reason for delay. And again, I know you guys are used to this checkbox and kind of having to memorize what counts as a non-system reason for delay, referring to our coding instructions to figure that out. And here we've kind of taken that guesswork out for you guys. Instead of saying, checkbox, is there a documented reason for delay, whether it be system reason or non-system? Once that's selected, it will have a multi-select field here. We're able to select all the different reasons. And again, this is going to really help for drill downs and quality improvement care, and I will go into that a little bit in a future slide that I'm coming just to in a minute. But again, we have all of our system reasons down here with asterisks and our non-system reasons here. So these are the ones that are listed in our coding instructions. This does not change our measures, the measures you're used to, all of the reasons that you're used to selecting for non-system reason are going to be here and will appropriately exclude patients. So we just want to make it clear that while we're changing the data collection, the measure is not changing. And again, we have the same thing here for EMS non-system reason. For delay, we painted to a documented scene delay and a multi-select. You can check all the different reasons for delay. And what that allows us to do is move away from just looking at the measure as a whole and really drill down into seeing what is happening with your patient care. So we're used to this measure, just running it and seeing what the fallouts are. And usually you can stipulate that you've had fallouts because there was some reason for delay. But now you'll be able to say, what were those reasons for delay? Are there specific reasons that typically are, more prevalent than others? Is it happening with certain facilities more than other? We'll be able to drill down and really get to a more granular detail of what is happening with patient care and how we can utilize the Get With The Guidelines CAD registry as not just a registry to put data into and expanded populations, but how do we move this to being more of a QI one-stop shop for you to really utilize it to improve patient care as well. And again, while our first phase right now is just to enter all of this, into the tool, V3 is really going to go into phases. The first phase is being this data collection. You're going to see the ECRF changes happen. The second phase will include these reports. So this won't be in the first iteration, but it's coming. And as always, we have many resources available to you guys. We have training webinars like this. We will hold office hours as we get closer to that release and right after, so we can answer any of your questions while you're abstracting data. We'll have updated coding instructions. I know a lot of you have been waiting for some changes to that. So we'll have updated coding instructions to reflect all these changes that are happening, a new CRF. We will also create a new uploader sample template. So that way you can update your template for all these new data collection elements, as well as the changes to like the reasons for delay, and get that all up to date. And as always, you have your QI consultant, formerly, your AHA quality improvement representative, to go ahead and ask questions to. And a lot of these resources are not available quite yet, but they will be. And I'm going to talk about that here in this timeline. So right now we're here in December in our webinar, and updates are in development. In January, we're going to have user acceptance testing beginning. And we will have another webinar as we discussed. We don't have a date for that just yet, but I will get back to you with that soon after the holidays with the webinar date and a link to register that will come through the same way that you heard about this one through our IQVIA emails. So please keep an eye out for that after the holidays. And we will then move to giving you resources in early February. And as soon as I have some of that available, I will go ahead and start releasing that to you guys. Just so I know, it's just so you have those and you're prepared and ready, and you can start asking any questions that you have, and we can get you prepared for any of these changes that might seem a little daunting, hopefully not. We'll then move into final user acceptance testing and the release in mid-February for this initial data collection enhancement. So this won't include all the reporting yet, but we are working on that, and we'll continue to have webinars and update you guys on the development of those reports. As Jason mentioned, we're hoping to create our CAD user group and get some of you guys in the tool and testing this new data collection as well as those reports. And this will, as this arrow indicates, continue on for us so that you can also help us with the testing for the reports and give us new ideas of what will really help you guys. So If you're interested in joining that, please reach out to your QI representative. We'd be happy to have you guys join us in any testing that we do. Jason, do you have anything to add that I may have missed? Otherwise, I think that we are done with our little intro on CAD V3. All right, well, thank you guys for that. Again, if you have questions about CAD V3, please email your AHA/QI consultant. If you're unsure who that is, you can email missionlifeline@harp.org and we will get you to your representative. And on that note, as Jason mentioned, we have a few other exciting things to share with you guys. One of these is our Get With the Guidelines CAD Target Type 2 Diabetes Honor Roll update. So starting in 2024 awards based on the 2023 data. So this will not be your spring awards that are happening, in April, May of this year. This will be the following year, but based on your 2023 data, there will be a new opportunity for a new award for Target Type 2 Diabetes. We will have a webinar on this on Tuesday, January 31st from 12 to 1 Central Time, where we'll be able to give you a lot more details on what exactly this entails. The webinar registration link will be sent to you guys tomorrow from IQVIA, and we'll also have it in this slide deck and everything. So we'll get that out to you guys so you guys can listen in and hear this exciting update on a new award opportunity for you guys. As a reminder, the data collection for diabetes was added in December 2021, so just about a year ago. And we've held some webinars on that in December as well as February. So this will just be another one to get you up to date on what's happening with Target Type 2 Honor Roll. And I will now hand it to Mindy Cook to talk about our rural health opportunity.
Thanks, Sandeep. Appreciate it. As mentioned, my name is Mindy Cook. I'm the National Senior Director for Rural Health Programs in our quality portfolio. So I've had the pleasure of, over the last couple of years, working with our Coronary Artery Disease Advisory group of volunteers from across the country to really look at bringing an equitable solution to our recognition programs in the coronary artery disease space. Really going back to the need for this being identified in the call to action for rural health presidential advisory that was published in 2020. This publication, if you haven't had a time to take a peek at it, really does go into detail on the disparity that's been identified in mortality for residents across the US living in rural versus urban areas. This gap began in the 80s and has continued to widen over the last 30 years, really resulting in a 3-year shortened life expectancy for residents in rural areas and a much higher increased risk of mortality due to cardiovascular diseases. Here at the Heart Association, it is our priority to mobilize our programs to help bring this gap in disparities back together over the next several years. The area of influence that we have here is within the arm of improving healthcare quality. So I'm going to talk a little bit about our programs to support that in the CORA space. But we also, through that publication, saw 2 other areas of opportunity put forth as those that are a priority and areas of impact that we can work on. And those are to expand our work in public policy around Medicaid expansion and telehealth access and support workforce development. And thirdly, to address risk factors through our outpatient and community impact programs, such as HeartCorps, the Social Impact Fund, the Health Equity Research Network, and reduction in tobacco usage. I'm here today to talk a little bit about our rural programs in the coronary artery disease space. Next slide. And to that end, we launched a program this summer that happened to, oh, you can move to that. Thanks, Sandeep. We launched a program this past summer that is a national initiative called the Rural Healthcare Outcomes Accelerator, in tandem to our work around rural acute recognition in our Get With the Guidelines quality programs, to really expand access to utilization of our quality programs at hospitals serving rural communities across the country. This enrollment criteria is the same criteria that we're using to allow eligibility to our rural acute recognition programs within each Get With the Guidelines module. So all critical access hospitals that are federally designated and short-term acute care facilities that are located within rural urban commuting areas as classified by the census tract data into rural, large, small, or isolated areas are eligible for our Rural Healthcare Outcomes Accelerator program and our Get With the Guidelines Rural Acute Recognition programs within 3 focus modules of stroke, coronary artery disease, and heart failure. So we have partnered with some of the well-established programs to define rurality, and one of those is the Health Resources and Human Services Administration page. So if you're wondering, and you're joining us today from an area that serves a large rural community, and you're wondering if you might be eligible, or some of your partnered hospitals might be eligible for the accelerator or the rural acute recognition programs, I'd encourage you to take a peek at the MI Rural tool supported by HRSA as a first step in looking into whether your community might meet that criteria. The Rural Accelerator, beyond recognition, also offers participants access to our Get With the Guidelines stroke, coronary artery disease, and heart failure modules that are newly added to their programming through 2025 at no cost. We've built out a specialized rural quality consultant team that will be also assigned and providing one-on-one support to each of those facilities enrolled. We're standing up virtual learning collaboratives within each condition to support model practice sharing and protocolization and streamlining of care. We've also put together continuing education bundles within each condition that are virtual and on demand that will be made available to rural hospitals to really ensure that they have the tools and resources at their fingertips to educate clinical staff at the bedside on the current evidence-based recommendations. We're also providing AHA professional membership, rural community network participation, and lastly, our recognition program materials and community resources. Next slide. We understand, and I grew up in a rural area and continue to actually live in a rural area, the unique strengths and opportunities available within the rural space. And I'm so excited that we're able to bring this kind of equitable approach to recognition within our Get With the Guidelines coronary artery disease module. Hospitals serving rural communities are essential services to those areas and really provide a personalized approach to care that we don't often hear about or see in more urban areas. They have great strengths in longitudinal relationships, which is something we want to continue to support with our systems of care work and partnerships with other organizations who might be able to help with resources in the rural space as well. Next slide. As Jason and Sandeep alluded to, we are launching our Get With the Guidelines Coronary Artery Disease Rural Recognition Program in 2023. This will relate to cases entered within the calendar year of 2023 and will begin issuing awards based on quarterly data within that calendar year. So we're excited about that. We have 3 clinical experts who will be joining us to share a description of this program and talk through the background and really get into the detail of the scientific rationale behind each of the new performance metrics. The Rural Acute Coronary Artery Disease Program breaks into 2 arms. So there'll be 2 recognition opportunities within this program, including the STEMI patients that we've all been familiar with capturing within coronary artery disease, and really is a great strength of our programming. We have some new measures that will be launching with the Rural Acute Coronary Artery Disease STEMI arm that really relate directly to the cares provided to STEMI patients prior to transfer and assist with throughput of those patients in the ED to move them on to definitive care with PCI at a center with those capabilities. Within the chest pain and acute coronary syndrome arm, we also have 7 performance metrics, some of which are an adaptation of the non-ST elevation ACS metrics we have in place now, and some will be brand new to performance based upon chest pain, throughput, and risk stratification, which we're hopeful will bring great value to hospitals that are serving these rural areas and haven't had the ability to collect chest pain and acute coronary syndrome patient performance up until this point. So I'm not going to spill the beans on the entire program during our talk today, but I just wanted to give you an idea of the structure of this program and a little bit about what we're going to cover with our volunteers on the 26th. I hope you can all join us and plan to put this on your calendar. And even if you can't join us on the 26th, please register so you receive access to the recording after the event. I think it's going to be very well done and go into great detail on the evidence behind each of the performance measures and the methodology for the composite rural acute coronary artery disease award. Next slide. I think that's all I have. I'm happy to take any questions or turn it back over to you, Sandeep and Jason, for the Q&A period.
Thank you, Mindy. That was great information, exciting. We have so much going on for CAD right now. We will now be taking some questions. Just a reminder, you can submit questions through the question pane in your attendee control panel. We're going to answer as many as we can through the chat and live today as we can. We'll go ahead and get started. I'm actually going to pull up, go back in the slide deck for this question so we can take a look at this. Apologies for that right now. Let me go ahead. It was here. So under ED disposition, there was a question of what is the difference between admission and transfer to acute care. I think it's transfer to acute care, but they said transfer to acute care unit. Admission would be an admission at your hospital, and transfer to acute would mean that you transfer to another hospital. And then we have another question about the data timeline and that we're going to be using. So this is going to be available in February 2023, and from that time period on, all patients will be under this version 3. Now, if patients are entered for 2023 admissions before we do the update, there's no need to panic. The measures will just run on that form, but you will not need to go back and do any abstraction or re-abstraction or delete patients or anything. The measures will go ahead and run on whatever form version that patient is under. So just continue with your abstraction. There's no need to stop and wait for this update to occur. Please go ahead and continue to abstract data as you do. And in February, we will move over to the version 3 form, and you'll continue to abstract 2023 data on that version. But if you abstract any 2023 patients, patients with that admission date from January till our update, that is okay to go ahead and have that in our version 2. The measures will run appropriately. So there should be no impact or change to what you're doing currently. You will just go ahead and make changes when we go ahead and get to the update. Another question that we have is about our vendors. We actually have a few of those. So I want you guys to be aware that we have had vendor calls, and they are aware and they've been kept up to date on where we are in the process for these updates, and they're aware they're coming down the pike. And we will get them all the specifications that we can as soon as possible, but they are aware of these updates. And they were also invited to join today's webinar to get some more information, and we'll be giving them more information as soon as we can. I also see a request for FAQ submissions. So I'm really glad to hear that, because I worked on that submission for some of our other registries. I would be happy to create, you know, an FAQ with questions that we're receiving and get that out to you guys as another resource. So we can definitely make an FAQ for our CAD questions. Mindy, I have a question for you. We have, where can I register for the CAD Rural Acute Recognition Program webinar?
Yeah, we can send it out to attendees from today. It is linked in the slide deck that I shared. So on that slide where the 3 volunteers are pictured, that link is active, but we can send out the actual save the date to attendees today and follow up as well. Yeah.
Yeah, I'd be happy to send that out with everything. We'll make sure to include both registration links for both our diabetes webinar as well as our rural acute. That's great. This is a great question. We have a user who's asking if we volunteer as a user for V3. I'm assuming with the V3 user, our customer focus group, will we need to enter patients in both forms? So the testing, we haven't decided if that will be a beta test to bring you over earlier. It would mostly be in our testing environment. And so I'm not exactly sure if you'd have to, you know, I don't think we'd be making you enter in both places. Jason, please feel free to let me know. I know you've been working on this with our stroke folks. They were on a different timeline and had a whole beta system. So that's probably where this is coming from.
Sure. No, so in general, when we involve external users, such as yourself, in UAT, user acceptance testing, we'll usually provide a test environment of your facility in a lower environment that'll allow you to abstract cases in there as a test. There will be absolutely no requirement for you to abstract in both, at the same time. When the version becomes available, all users will see that the new version of the form, and all records, newly created records with a discharge that's past 2023, will then see that form, and they'll just begin using that after launch. But before launch, while everybody was still in version 2, if you opt to be a part of that user group and we have you involved, then yes, then you could go in and you could just put in some sample cases, really to get the feel, the look, the layout. It is very impactful to us to have users entering in live cases into the test environment because that's the only way for us to get that true workflow and care pattern as you abstract that data in, way beyond just putting in a sampling of options as we just kind of peruse through it. So we do want that real life experience. There would not be a requirement for you to do both if you didn't want to work in the test environment.
Thanks, Jason. I have another question I think you can help me with. There was a mention of aligning QI improvement and data metrics with certain specialty accreditation bodies. Which will these include, Joint Commission, DNV, etc.?
Sure. So our registry currently, Get With Guidelines-CAD, does align and include all of the metrics needed for all of the Joint Commission cardiac certification. So utilizing the Get With the Guidelines-CAD registry, you can meet all the data requirements and all the metrics are included, and also electronic data submission of that performance quarterly to the Joint Commission is all available within the CAD registry. So all of our metrics, do align with Joint Commission in regard to that. If you're interested in any of those certifications, please reach out to your local QI manager that can take you through that process and give you some more information. But acute heart attack ready, primary heart attack center, and comprehensive heart attack certification are all 100% supported by the Get With The Guidelines CAD registry. Now, beyond that, right, because there's a lot of things that are also in specifications that look at different segmented times and goals and benchmarks that are kind of beyond the standard reporting metrics that you have to have. Yes, the goal is, much like we've done in our other disease states, is to provide tools and reporting, not used for awards, but reporting and tools in the system so that you can go in and run a period of time of all of your responses to high-risk chest pain, STEMI patients, and truly drill down into those to look at what are all the segments of care and the performance in each of those metrics, of arrival to position, to ECG, to cath lab, to cardiac alert notification, right? All those different segments of time. We want to make the tool positioned in a way so that you have that, and then also give you the opportunity to report on those metrics for whatever purpose you need it for, whether it be Joint Commission, whether it be DNV, any of those types of things. So a lot of good things coming out in the future, but our system currently does the joint certifications with Joint Commission and the American Heart Association for acute heart attack, primary heart attack, and comprehensive heart attack are 100% supported by the Guidelines CAD.
Thanks, Jason. There's a question, actually 2 questions about our LV assessment. So I know right now that it is requiring that value to be filled in for different scenarios of if it been taken at this hospitalization or prior. And I'm actually redesigning that per your guys' feedback to change that to ask if first, and I'm sorry I don't have that up for you guys, but in the next webinar, I will be sure to show you guys this. Since I know there's some interest here, I'll make sure to do a demo of this specifically, this update for the LVF assessment, where we are now switching that into asking first, when was this taken or is it planned? And if so, what is the value, and requiring the value only in the situations where you would have an actual value. Because I know that currently there's not an option. We'll also have an option for not documented, because I know that is also impeding a lot of measures, and in such cases there isn't anything to document. So we will also have the not documented option for that question. So I will be sure in our next webinar in January to do a demo of that specifically, since I see that interest in fixing that and enhancing that to really work with your abstraction process. Go ahead and see what else we can answer. I know we're getting close to time. Will there be a report that shows door to EKG in 10 minutes, including all patients and only those who qualify? Yes, that data can be pulled through a data download and the time tracker, and we will be sure to enhance that. I love to see this feedback, so we know what are those reports that you'd like a little bit more detail on and how we can highlight those more. So I will make sure to make a note of that. Is there any chance to get metrics done for all MI patients instead of breaking it between NSTEMI and STEMI?
Sandeep, I can just add a little context here too. This is such a great question, and one thing that, into this year and into next, what we really want to bring the system into is answering some of these questions like this one, which is so pertinent, is that the achievement and the quality measures reporting into your award are fantastic. We need those to support it, but there's so many more questions that you, your colleagues at your hospital, your administration, your coordinators, your ED, that want to know, right? Holistically of your patient population and your response. So the goal is to move in the direction to have more broader reporting measures, just as like what you're describing. So, to give you the ability within the registry system, so then when you run these metrics to look at all MI patients that receive, let's say, beta blockers, for instance, you can then have filtering options to then drill down on those individual patient populations you want to, instead of that happening initially with the initial patient population, because we have heard back from you all where there is challenges where you have to run two separate measures to look at your STEMIs versus your NSTEMIs for very similar care. So we want to eliminate that barrier. Those measures will still exist, obviously, for achievement on awards, but we do want to make a much more simplified version of you looking at your data and reporting measures. So that is something that we're definitely moving in the direction for.
Thank you,
Sorry,
Jason.
Sandeep. Thank you.
No, thank you, Jason. And to that point, I know there's a few more questions that are very similar to that, and these are some of these items that you guys are bringing up we have heard and some we haven't. So I'm going to take these back and collect them, and I will answer them in the FAQ, just because I'll need to do a little bit more research on some of these and work on them, and some are brand new to me. So you know, if you didn't get your answer today, please know that we are not ignoring you. We will go ahead and email you after this webinar and get back to you on those. And someone has brought up to an issue that they're experiencing in version 2 as well that I haven't heard of. So I'm going to go ahead and also look into that and get back to you as well, Margaret. I haven't heard of that yet. So thank you for bringing that to my attention. And thank you all for attending. On behalf of the American Heart Association, thank you for participating in Get With The Guidelines-CAD and joining us today to hear about these updates. Again, I will go ahead and get through these this FAQ, and if you have more questions, please feel free to email your QI consultant and they'll get them over to me. And I'll start to develop that FAQ as well as get back to you, some of you individually, to see if we can enhance the tool further and make sure that it's really a QI tool for you guys to really go ahead and improve patient care. We hope you had a great holiday. We hope you have a great holiday season, and we will be in touch in the new year. I'm sorry about that, you guys. I'm a little sick right now, but thank you again for attending, and have a great rest of the week.